talk about the new device for osteoporotic compression fracture. Once you learn or you get used to this system, probably you can try to use this system for some probably more complicated than the osteoporotic compression fractures. And it's a great pleasure and honor to have a spine surgeon from Spain, Professor Francisco Odra, all the way from Spain. And he's a very experienced spine surgeon. He's been using this system for 7 years, and they have done probably like 500 cases already. I think his experience sharing can let us learn a lot of about this device and how we can use it, or you can get to know this device. Please welcome Professor Odra.
Is it working? Okay. So first of all, thank you very much, Dr. Chan, for your nice presentation, and thank you to the organization for your kind invitation and letting us be here to share our experience in the use of the treatment of PCF. So what I want to talk first is about the concept of anatomical restoration. It's clear that if we have a fracture, if we are able to treat it in an anatomical way, that way we will have the best results in terms of pain and function. And where does this term come from? We'll take a look at why do we need to treat PCF, in what way can we treat them, and what goals should we achieve, how we can manage not only pain but also the fracture and the deformity, and we'll take a look back to the historical ways that we've been using to treat PCF and that have led us to the place that we are today. So it's clear that when we have a vertebra and we have a VCF, a vertebral compression fracture, it's not only a bone fracture, but we have to take into consideration that it is a joint, and probably a much more complex joint because we have one disc above and below, and we have 4 facets that are involved in that fracture. So we think that we should treat them in the same way as other fractures that are affecting a joint. We treat them to treat the clinical symptoms, mainly pain and the decrease in quality of life, but we also have to address psychological symptoms and, of course, what is most important, the biomechanical changes that happen when we have a VCF. Because we have the loss of anterior support, we have the change in center of gravity, we have overload of adjacent vertebra, and those are going to lead to a higher rate of adjacent fracture, chronic pain, muscle fatigue, and so on. And also we have to treat VCF because it's a big problem, both in cost and social terms. You can see the estimation for the US for the treatment of VCF every year is a high amount of money, and many patients are involved. It's not new what we are talking about, but I don't know why we have been treating joint fractures with arthrodesis when we are supposed to preserve motion. Already in the 60s, Chanley talked about the perfect anatomical restoration in order to get an early mobilization for fractures. Also, the AO, in those terms, talked about anatomical restoration, stable fixation, and early mobilization. And even tricky, in the 70s, he already published that a poor prognosis is for those fractures when a joint is affected and we have a consequent impairment of movement. So it's clear that we should treat these fractures in an anatomical way to achieve these goals, with that anatomic reduction and early mobilization. So it's not only about treating pain, which will probably conservative or vertebroplasty could do fine, but we also have to try to achieve the local anatomical restoration, and that this local anatomical restoration is translated in global restoration of the spine. And also, the fourth point that we have addressed is to avoid the complications both in short and long term. And which are those complications? You already know: loss of height, the loss of pelvic rib distance, disbalance, adjacent fracture, disc degeneration, and even mortality that we know that is increasing patients that have a PCF. So why is it important not only to treat the height of the vertebra, but also the end plate, which will lead to an anatomical restoration? There are several publications that already talk about the deformity post-fracture that is responsible for an overload of the upper vertebrae in more than 94%. That means that when we don't treat the deformity and we don't restore the end plate, the adjacent vertebra is suffering twice the compression that is used to suffer and it's supposed to do. So when we have a wedge fracture, it encourages the presence of a new vertebra. We already know, but what works like this one says that it is due to the lack of restoration on the end plate. And we also know that not only the end plate, but also the disc is important, not just as disc degeneration, but also in terms of adjacent fracture and new fractures. When we have a normal disc, the loads go from posterior to anterior in a stable way, and when we have a disc degenerated, we have an anterior and posterior peaks, what makes that there is a bypass of forces, and we get resorption in the middle of the vertebral body, what may be a factor for new biconcave fractures. And there is another point, like this work made by Honor from a Dutch group that are very hard on BCF investigation, and they see that the disc is involved in the progression of the kyphosis in 30% of the cases. If you have a pattern of disc degeneration like this one, after a BCF, then only because of the damage of the disc, there is a 30% of risk of progressive kyphosis. So it's just not about the bone, not just about the height, but also the end plate and the disc that we have to treat. And those local changes must be translated into the global spine so that we can correct the balance, because if we have a positive balance, we will have changes in the rachis load and increase bending moment, what will be one of the factors to keep on having pain, chronic pain, due to the dorsal muscles fatigue, and an adjacent fracture due to the overload of the anterior column. So probably before now we were not treating the spine in this way, not because we didn't have the idea, as you see that this idea comes from the 60s and the 70s, but because we were not able to do so. We did not have the instruments to treat the spine and the BCF in such a way. In terms of pain management, in the short term, of course it is enough with the stabilization, that we can get it with percutaneous vertebral augmentation, and we can restore the strength and the stiffness of the vertebra, but we have to try to avoid the complications, mainly leakage in such techniques. But in the short term, we have to know that the pain cannot be only controlled by primary stabilization. We need a long-lasting anatomical restoration to avoid the fatigue muscles, the deformity, and the new fractures. So we need something able to reduce the fracture, to fixate, but in a long-term way. And in terms of fracture management, how can we do that? How can we achieve the anatomical restoration? There are several steps, but what we have to keep in mind is that it is not only about achieve a result, but if you achieve a result and you lose it, like happened to Spain in the last World Cup, then it's not worth it. You have to achieve and maintain your result. We do it in these 4 steps. First one will be bone fragment reduction, which is the key to have the best results. We can do it through ligamentotaxis, which is always important, but we know that with ligamentotaxis we can pull the cortical ring, but we are not able to have any action on the end plate. So we have to act from inside the vertebra if we want to push the end plate up. We can use the balloon as we were using before, and it was a very important step. Those are internal and control forces because we don't know, and you have the experience, how the balloon is going to behave when we start inflating it. We don't know if it's going to go up or down or going to the side. Or we can use devices like the spine jack that apply control forces and in the direction contrary to the one that provoked the fracture. That is a concept that we should manage to apply the contrary forces to the ones that provoke the fracture. Next step is to provide a stable fixation. We can do it with screws, or we can do it with PMMA, with cement, which seems much more natural, right? The third point is that we should achieve all those changes that anatomical restoration should be in order to achieve biomechanical restoration. This is an example of a fracture of a patient from our center, and after 1 year follow-up treated with Spanjak, the survival of the disc. There is a nice poster that we also brought talking about MRI weighted diffusion and survival of discs after BCF treatment with this compared to conservative treatment. You can take a look at the poster exhibition. And finally, of course, for the future, we need the biological response. What is the future? Probably to be able to use cements that are completely resorbable and that provide weight-bearing properties, but we don't have that yet. And we were not the creators of this implant. We were not the only surgeons treating BCFs in the world. So we have made a long way until we reached to this concept, to these kind of devices. When we started using conservative treatment, and the conservative treatment has big limitations. It has only a property of using ligamentotaxis in order to reduce the height of the vertebra, but we are not going to be able to correct the end plate. And there are many studies always comparing conservative to vertebral augmentation, vertebroplastic to conservative treatment. And the last studies, as this one from 2013, you can see that the cost of vertebroplasty is the same as conservative treatment in the first days. And the problem is that conservative treatment, they have a 5% of readmission. So really, when we are told that these techniques are expensive, maybe they are not so expensive if you really study them. And you can see, like this other study, it's a meta-analysis published in Bone and Mineral Research, that cementoplasty has better results than conservative treatment. I don't know if you have experience, but the results with cement augmentation, in my experience, are really, really good. So many times, when you have an old patient, you could do conservative treatment and have them for 2 months or 1 month in bed, but that's not what they are looking for. When we have a cold, we could just wait for the cold to go, but we try to have analgesic, paracetamol. We don't like to be suffering, to be with fever. So why should we suffer from the consequences of the conservative treatment in BCF when we have such easy and low complication techniques? And another problem is that we don't know, we cannot tell the patient what the fracture is going to heal like. If it's going to have deformity or not, if it is going to heal correctly or in such a way in a young patient like this one. And we cannot tell the patient if he's going to have to undergo a new surgery in future. I want to show you concerning posterior fixation and instrumentation. This is a very nice study from the German Association Trauma Society, and they made a prospective study comparing posterior, ventral, and 360 fixation in thoracolumbar junction. And you can see that from the pre-op to the post-op they get very nice results, but they lose most of the reduction is lost when over time. Okay, with dorsal instrumentation, with ventral instrumentation, and even with 360, we lose reduction on time. These are the best results, but this is a very aggressive technique, probably for a BCF. The next step in the treatment of BCF was the cementoplasty, mainly with vertebroplasty. We got very good results in terms of pain, but in terms of reduction and anatomical restoration, we only have the effect of ligamentotaxis, and again, we don't have any action on the end plates. So to solve this problem, the balloon was developed to use forces from inside the vertebral body, but the truth is that the results in long term has shown that the balloon is not superior to vertebroplasty. There were big expectations and hope on balloon, but I think most of us have gone back to vertebroplasty or to new techniques. Finally, we have the effect of ligamentotaxis, but we know that the effect on the end plate is very limited, and that most of the reduction is lost during balloon deflation. We have some biomechanical studies that show that the reduction with balloon is similar to vertebroplasty when we apply cycling loading on time. So is there anything else that we can do from balloon? Well, someone developed, it's a French surgeon who developed the spine jack, and what we are looking for is the effect of the gametotaxis that will make a restoration of cortical height, but we also will have action on the end plates, which is very important in these cases that we have seen, and we maintain the correction while we do the cementation. And we also minimize the risk of leakage because the cementation is very predictable with this device, as Dr. Chiang will show you in his presentation. So in conclusion, up to the 21st century, we've been treating patients in a conservative way or surgical way without fluoresces, and at the end of the 20th century with vertebroplasty. There are second-generation treatments that are balloon kyphoplasty, but I think that we are now in a third step that we can treat BCF in an anatomical restoration way with a cortical ring restoration and also action on the end plate to avoid complications, the adjacent fracture, the degeneration that happens in this patient after BCF. Thank you very much.
Thank you, Professor.
I think we have another presentation. You want to? Yes. Okay. So I will show you some of our experience. We have a prospective multicentric study. We were going to show the 12-month follow-up because we just got the data 2 weeks ago. So instead of 12 months, I am going to be able to show you the 2-year follow-up results. It was a study that was carried out. Already working. Okay, so it's a prospective consecutive study, multicentric in 6 countries with 14 centers. We enrolled 103 patients included, some with several fractures, and they are all acute trauma fractures. The primary objective was to evaluate the clinical and the radiological results, and the secondary objectives to assess the perioperative and long-term feasibility, safety, and performance of the implant, and if it was able to assess the anatomical restoration. So these are the centers that were used for the study. And you can see that we lost some patients over time. So we got 78 patients at 1-year follow-up and 57 after 2 years. The age, I think, is the typical patient that we're having in our clinic. 50% females and males, and they are fresh fractures. That is important because all of these techniques benefit from mobility. If there is no mobility, then there is no way that you can get anatomical restoration. Most of the patients were trauma cases, and some of them were low energy trauma on osteoporotic bone. Okay, that is most of the cases that we have also. You can see that more than 50% of the patients, they had A3 or B fractures. B fractures should have not been included and cannot be treated only with the spine jack in our experience. We have treated B fractures adding dorsal instrumentation to the spine jack, but only with the spine jack and cement cannot be treated. But they were misclassified by the investigators and they were included in the study, so we have to follow them. So 50% of the fractures were complex fractures, and you'll see that the results are pretty good. This is the distribution of fractures. And in the trauma group, you can see that there were more males than females. And in the osteoporotic group, most of them were female. All of them were painful, close to 7 in DAS, high OD disability, and low quality of life, under 50 or around 50 most of the patients. The procedure, if you are used to that type of approach, is not a long duration procedure, less than 40 minutes, I mean. We were using around 6.7 milliliters of cement, and the mean duration of hospitalization was 4.3. In our center, the patients go home the day after surgery. But in countries like Germany, if the patient is not in hospital for 2 days, they don't get reimbursed. So they have to keep the patients at the hospital. But in our center, the day after surgery, they go home. If we take a look at pain, look what happened. There is a reduction in pain of 85% after 2 years. The results are stable after 1 year, and even the pain decreases. And it's very good results in terms of long-term pain reduction. In terms of disability, you can see that it's the same result as for pain. The stable results after 2 years, and 89% decrease of OD score. As an example, we can see the intake of analgesics. After 2 years, 98% of patients were having no treatment or mild analgesic treatment, which is a very nice result. And the results improve on time, as you can see. They don't deteriorate as could be expected. They keep on or they are stable or keep on improving. And finally, in terms of quality of life, you can see that there is an increase from the pre-op to the post-op, which keeps it stable, and it is a 52% of increase in quality of life. So the patients really appreciate that the situation has changed and that their life is better. In terms of radiological assessment, we use X-ray. We use a software that is approved by the EPA, and it was an independent laboratory who analyzed all the data. And we only have 1 year follow-up in X-ray data because most of the patients did not accept to get a new X-ray after 2 years because they were doing fine. And for example, in Germany, if the patient is clinically stable, there's no reason ethically to get a new X-ray. And most patients did not accept to get a new X-ray if they were doing fine. But what I can show you is that there was a significant reduction of vertebral kyphotic angle. We got an improvement of 5 degrees, what means more than 30% of improvement in the kyphotic angle. And the results deteriorate a little bit on time, but still we have a significant correction of the kyphosis. We only lost 1 degree in 1 year time, and the results were stable since that. And even in the A3 fracture group, which are more complex fractures, the improvement is much better. It's up to 7 degrees, what means a 50% of correction of kyphosis. And at 12 months follow-up, we still have a nice correction, even when the radiological results deteriorate a little bit. As you saw in the presentation before, that even with posterior and anterior 360 approach, we always have a loss of correction. About complications, in the A3 group, the leakage was 32%. It was lower in the global seria. It was around 23%. But you can see that in complex fracture, even it was like the rates that we are having in other techniques and other reports, and there were no symptomatic cement leakages. And finally, there were 13 serious adverse events that we have to follow in such a kind of study. 2 patients died, but there were no adverse events related to the implant. In terms of new fractures, we only saw in the first year 3 patients that presented adjacent fracture, which is a very low rate of adjacent fracture. And during the second year, there were no fractures. So after 2-year follow-up, there were only 3 cases, and those 3 cases happened during the first year. So we don't expect to have new fractures, since we saw that after 1 year and after 2 years, the rate is the same. So what can we say to conclude? The clinical and radiological results confirm that this system is safe. That is the first thing that we are concerned about as surgeons, and is efficient since we get what we want to get, and on the long term they are stable and the results are consistent. And finally, that we have a very low rate of adjacent fractures, 2.9, which means that we can avoid the complications with a low rate of leakage and a low rate of adjacent fractures. I will just show you some cases. This is a case from a man in our hospital with a very osteoporotic due to hormonal suppression for a prostatic cancer. And he fell from a chair and he had this kind of fracture. Not very painful, 5 in VAS, but with a big deformity. This was translated in a big disbalance. So we wanted to treat not only the pain but the deformity, and we made an spine jack, and this was the result. We were able to act in the middle of the end plate and correct the kyphosis. This is another trauma case in a young patient, 30-year-old, with an A3-1 fracture. This fracture, a big hole here where the disc can collapse in, was treated with spine jack and cementation, and this is the 12 months CT. You will see how the cement distributes all around the vertebral body, underneath the end plate, crossing from one side to another. And here we made 3D reconstructions to see what are the changes from the pre-op to the post-op. Okay, and we can check where every point was pre-op and post-operatively, and we make a color code so that we can see how much those points change their position. You can see that in the middle of the end plate we are able to act with this device, which is not possible with ligament ataxis. Here another young patient, 20-year-old, with a pre-op A3.2 fracture, posterior wall displaced, nice reduction, no leakage to the disc. Underneath the upper end plate, all the cement placed, and 12 months CT with stable results, and 12-month X-ray with a great correction, also in terms of pain. And again, you can see how we can have a big action on the end plate to correct the position from the pre-op to the post-op. And finally, another case, a 64-year-old woman with this fracture, A3.3, with both end plates affected, and how we can place our implants even when we have the posterior wall broken or the proximal part of the pedicle, and we can place our implant, fill with cement, get a nice reduction, parallel end plate to the upper one, and nice disc and consistent results after 12 months. And again, how we can act in the middle of the vertebra, in the middle of the end plate, that was something that we were not being able to do before. Thank you very much.
Thank you. So I'm going to present our experience before we have our open discussion. If you are familiar with regular plasty, so it's not difficult for them to use this new device because it's the same procedure. Only thing is different before you inject cement, you just put it in the device. Well, this the spine jack is just take the concept from car jack. Actually, try to use the force from within the inside fracture of the vertebral bodies, and to elevate the end plate and restore the anatomical height of the vertebral body. And this our case is a 71 female. She had a fall, so got a complete fracture at L1, and his T-score is -3.22. And this is a pre-op MRI. Actually, it's a multiple complete fracture. This one with scale enhanced is indicated as fresh complete fractures. And scale enhanced MRI is very good too to indicate the pain generator. So we just take this vertebral will relieve the pain. And so that's the procedures. Hopefully, it's like wrong. See, you can see the device. When we expand the device, it's very easy to restore the disc height. So once we restore disc height, we can just put in the cement. And So once this, because the device expanded, so there's space just inside the device. So you can safely put in the cement and you don't see any leakage unless you push too much cement. But if you get familiar with the device, you know how to prevent the leakage. But most time, just Professor Otto said, is asymptomatic leakage. This case 274 female, fracture L3, the VAS score is 7, T-score is minus 2.31. And the pre-op MRI, you can see it also is multiple complete fractures, but the L3 is the active complete fracture site with ghetto enhanced, indicate this level is the pain generators. And so we call this device. You can see how beautifully you can restore the disc with this device. And then put in cement. And you can see it's L3, can have very good velocity angle corrections. And it's a K3, also complete fracture L3, VAS is 5, T-score is minus 2.8. There's no trauma histories. The pure MRI has two previous old complete fractures at L1 and T12. She had a T12 vertebral palsy before. Now he has a new complete fracture at L3. And the ghetto enhancement indicate L3 is the active pain generators. And you can see, we can use this device to restore the disc height and angle, and then complete the cement. This is case 4, is 68 female. The fracture is at T12. She had these problems because she did housekeeping work. She cleans her house, and after work she felt the back pain. And in the VAS score is 6 to 7, T-score is minus 1.3. And the pure MRI indicates a complete fracture here, and with ghetto enhancement. And then we use this device. But sometimes we just use the device to restore the disc height, but we didn't to expand the device in the full expansion. In the full expansion, we don't want to create too much reductions. This is a case wise. I think it's the last case. It's an 83 female. That's complete fracture L1. VAS score is 7. She had a fusion surgery 2012, and then in 2015, actually it's not 2015, it's 2014, in October, she had a complete fracture at T12, so she had a spine jack treatment. And then 2 months later, she had another fracture at L1. T-score is minus 1.78. This is a brain X-ray. That's her first complete fracture. And you see it's, here is T12. So she had a vertebral palsy in this, actually it's correction with the spine jack. And that's the post-op image. You see this is a post-op brain X-ray here. And then she had the second complete fracture here. No, sorry, it's adjacent complete fracture here. It's L1. And with this device, we can correct this capillary deformity. So I mean, even the adjacent fractures can do the second spine jack reductions. So we want to know what's the difference between the regular vertebral palsy and also the surgery with spine jack. This is a regular vertebral palsy. You see, usually we use double barrel postural reductions. We can get a very good ligamental plexus reductions, and then put a cement. So postural image, you can see is a very quite good anatomical reductions. However, if you wait for 1 year follow-up, you can see this adjacent atrial personality is so-called subsequent fractures of the remaining bony tissues, and then we lost the correction of the body height. So one to know what's the difference between the spine jack and the regular vertebroplasty group in terms of the in terms of the maintenance of the body height after corrections. So we correct the cases from June to February 2015, and have a 97 osteoporotic complete fractures, and this is single level. 50 of them with vertebroplasty, 47 of them treated with spine jack. And we just measured anterior, middle, and posterior body height, and also look at the kyphotic angles. And that's our demographic data. This is a little bit older in the vertebroplasty group. So if you look at the kyphotic angle in the regular vertebroplasty, we can get a very good actual body height reduction 4 weeks after operations. But then we lost the correction 3 months after operation. So in the 1 year, we can even lower body height after regular vertebroplasty. With spine jack, actually in the 1 year we can maintain very good kyphotic angle. So that means with this device, we can keep the good anatomic reduction 1 year after operations. We have our PA to report this detailed information in her, I think in this presentation this afternoon. So the clinical outcome, you look at the bars, well, there's no difference between two groups. So 1 year after operation, the pain reduction is the same. But look at the adjacent fractures. Actually, spine jack didn't increase the risk of adjacent fracture, like what Dr. Odor just mentioned. If there's any remote confirmed fractures, actually it's the same as compared with the regular vertebroplasty. So the conclusion is this device can give us more control to achieve very good anatomical reduction of the disc, actually the body height, and also the ankle reductions. And also with this kind of reductions, we won't increase the risk of adjacent fracture of our patients. Thank you. I think Professor Albert and I would like to take a question from you. If you have any questions you want to ask.
Thank you for presentation. My question is that the spine jack, the spine metastasis in vertebroplasty, is this also indication for spine jack? Yeah.
I think we did one case. It's not in the original indications. Or you have more or
we have been using it for osteoporotic patients, for trauma cases, and also in tumors and metastasis. We got a poster also on our series with 36-month follow-up, and our results are very good in terms of pain and new fracture and subsequent fracture, and the patients are very happy. We even get called from the hematologist or the oncologist because patients are in pain, are not able to receive even chemotherapy or radiotherapy, and they look for the treatment with us, and the results are very good, even with big metastatic vertebrae that are without bone. And the problem is that you are afraid of leakage because there are no posterior wall, or it is destroyed. With the spine jack, it behaves very well, the cement, because it keeps around the implant, and all the cement goes through the implant in the most anterior part, running away from the posterior wall. So it's also a safe technique in such cases.
Dr. I have one question. about the spine check. One level use 1 or 2. Here divided into use one the spine check and the 2 spine check. Neck difference in the correction of the position level fracture.
Well, there's a problem here because the cost of the device. So some surgeons they would like to use one device to do the corrections. But for me, I usually use 2 devices to get corrections. How about you?
When you make a lumbar fusion, can you use 2 screws only? You can, right? But your results are not as good. So you could use 1 implant only, but your results are not going to be as good as they will be, because if you only pull or push with 1 implant, you will not be able to get the same results as if you push with both, that you will have a bigger area of effect, and that if you have a fragmented end plate, you will be able to raise off all the fragments and not getting into the disc space with some fragments and leaving part of the vertebra collapse. At the beginning, there were not different sizes of implant, so for thoracic levels, we only had the 5mm one, and we were not able to place the implant completely inside the vertebra through a transpedicular approach. And what we were doing was doing an extrapedicular approach and putting only 1 implant inside the vertebral body in the middle. Nowadays, there is a 4.2 implant that fits very well for thoracic levels, and we don't have to do that anymore. But we have been using sometimes only 1 implant, but the results are not as good as with 2 implants. But if the patient cannot afford anything else, there's nothing else to do.
Thank you for both of you and excellent presentation. I'm Dr. Song in the private hospital. I have one question. To what extent of the posterior vertebral body collapse and indentation of the spinal canal, to what extent we can expect the restore of the intention pre-operative? That means what kind of patient we can expect for this procedure if they have a fractured posterior wall?
Okay, so at the beginning, the device was not marketed for A3 fractures. We started using it out of label for A3 fractures, and nowadays it is marketed for A3 fractures, so you can use it. What we saw in our first registry in A3 fractures is that in no case, of course, we are always talking about non-neurological condition. The patient is completely normal in neurological examination. And in our series, we studied the first 35 patients that we made A3 fractures. We saw no displacement of the posterior wall, in any case, no displacement. And in some cases, the fragment even reduced and the diameter of the canal was bigger than preoperatively. It makes sense because it's not like the balloon that you could push the posterior fragment. You are not pushing anything backwards, you are just raising the end plate so that you make a space and room for the fragment to come forward, and you also give tension to the posterior ligament, which may push the fragment anteriorly. So it's fit for A3 fractures, it works nicely, and we are using it for A3-1 and A3-2 fractures with very good results. It is marketed for A3-3 fractures. I don't advise to use it alone with A3-3 fractures. We prefer to use screws added to the spine jack. But for the rest of A3 fractures, there's no problem with it. It works very well. And there's no problem with the posterior wall to be displaced posteriorly. I don't know if you have the same experience with A3 fracture?
Yes, we did some, but not many. Actually, still can work on in those cases. But it's very important, should be there's no any neurological deficit.
And you have to think of the spine jack as a reduction device. So even if you have a neurological condition, like some cases that we did, we made the decompression, and then we placed the spine jack. and added dorsal instrumentation because we made a decompression, removed some part of the arc, and prefer to use screws. But we also use the spine jack after the decompression. So think of as a reduction device that you can combine with dorsal instrumentation, or that you can make the fixation with the PMA, depending on the case and on your experience. In our first cases with A3 fractures, with A3 fractures, we were using screws. Then we dared not to use screws and be ready and advise the patient that we were going to do an easy surgery, and that if it didn't work, we may need to put the screws afterwards. The patient accepted it, and we were learning from that, and the results were very good, and we kept on doing it without the screws. And there is a biomechanical study that was just published, and I think that can be provided, where we compare the group using dorsal instrumentation, a group using a spine jack with PMMA, and another group using dorsal instrumentation and a spine jack with PMMA. The results of only dorsal instrumentations were completely worse than the other two groups, and there were no difference between using a spine jack and dorsal instrumentation. And these were A3 fractures. So at the end, what we saw is that the spine jack was not an added value to dorsal instrumentation, but on the contrary, it was all the value. And the dorsal instrumentation was not really necessary, because the results were the same with the spine jack and PMMA and spine jack and dorsal instrumentation. So what to use the dorsal instrumentation for? But this is a big change in our way, in our practice. So I advise that you try your osteoporotic cases, start slowly with easy fractures, and get your own experience, because we are surgeons and we live from experience. Yes, but I think that the rest of the people want. Do you want to use this?
Thank you. Do you fully explain the device in all cases? And how do you decide how much should we stop?
Okay, so there is a very good concept about this, is the control. We are surgeons, we like to have control of what we are doing during surgery. We don't like surprises. So the point is that you can choose when you stop expansion. You don't have to go to full expansion, as Dr. Chan said before. You can stop at any point, because the system has a blocking system so that it doesn't collapse when you remove the implant holder. And what we are looking for is not restoring the height, but correcting the kyphosis and looking at the end plates. So when I correct the kyphosis and both end plates are parallel and the shape of the disc is similar to the shape of the disc above and below are in progression, then for me that's a good result. So I have cases that the height is not completely restored, but the kyphosis is corrected and the end plates look parallel, and that's a good result for me.
Thank you, Dr. Odura. My question is, in hypoplasty, the expansion pressure is less than around maybe 220 psi, and how about the pressure point in spine check hypoplasty? Thank you.
Thank you for your question. So in the balloon, we are developing like 500 newtons, 400 newtons with full expansion of the balloon. With the spine jack, from the beginning, we are applying between 700 and 1,000 newtons on the very beginning. There's a concern for many surgeons, that is, can we break the end plate? Because that's osteoporotic bone, and we are worried about that. In our series, we have seen no fractures of the end plate, because the implants, the wings, they bend when they touch the end plate, and that's a very nice image to see on the X-ray, and you will see that they adjust to the bone, and that you are not going through the bone, and they are very gentle with the bone. So they deform before breaking the end plate, and they keep on pushing all of it together. We have some cases where we expected to be able to move something, and we had edema in steer sequences in MRI, but finally when we were in the OR, there were all cases and we were not able to move anything. So what happens with the implant when you try to open it and the end plates don't move? is that the implant deformates and it gets like a ball, like a mass of titanium, and then you just deliver the cement, and what you made was an expensive vertebroplasty. But if you have expectations to be able to move it, you have to try. But they deform and they don't break the end plate. It's very nice. Sometimes it's our mistake. Some cases that we know from Germany, they drilled with the reamer the end plate and they broke the end plate during the procedure. So the implant was placed where they drilled, where they prepared the place for the implant. But it was not the implant, the one that broke the end plate.
Thank you. I have 3 questions. Sorry. Is the spine tract implant remaining inside the body after the surgery?
Okay, so that's another concern. Thank you for your question. The people say, I don't want to leave an implant inside the vertebral body. That's a little bit weird to me. Okay, think that there is no implant. Forget about the implant, because what we are going to get is the cement in the implant and around the implant. So it's like when you do a vertebroplasty or a kyphoplasty and you put the cement, that's it. Forget about the implant being inside. So the implant is going to remain inside the vertebral body, surrounded by the cement.
When we perform later time, when we do pedicle screw fixation, is there any resistance from the implants?
Well, that will be a problem. You have to make instrumentation. Luckily, most of the fractures are in the dorsal-lumbar joint, and most of the degenerative disease are in the lower back, the lower vertebra, so that's not a very common situation, but it could. You still can, if you change and you choose the direction of your screws, you can still have place, because the implant is not in the pedicle, it's in the most anterior part of the vertebral body. So you could go with shorter screws or with longer screws in a different direction, more convergent, so that you can avoid the implant. For example, there is a case of a patient that we use a biological cement and screws. And when we removed the screws, we took a biopsy of the bone around the implant to see if the fracture had healed, and the result was normal bone. So we had room enough to get a biopsy. So if I can get a biopsy, probably I can place a screw also. So there's room for that.
And can it be done by extraperpendicular route, such as parallel approach, to deduct most of the complicated part is on center only? Can it be done parallel approach?
We made some. You mean paravertebral completely, or bilateral
approach? Only unilateral approach.
Okay. Yes. For example, in cases like complicated fractures that you have a pedicle broken and you don't want to go through it, or tumoral cases with myeloma, maybe insufflating one pedicle, we have made only one side approach. At the beginning, we even made some, as I told you, extrapedicular approach. But now with the small implant, we always go transpedicular, and we can go one side only. That's not a problem. In cases like myeloma, tumors, or fracture of the pedicle, you can do it.
Last question. When we're doing hypoplasty with balloon, sometimes there is not enough reduction occurred because the fracture is developed a long time ago. So at the later stages, the reduction is not good enough. So how is this product produces more power than balloon hypoplasty?
Yes, it does. It does. It's up to 1,000 Newton, and also it only expands in one direction, craniocaudal, so you avoid breaking more bone. And of course, you benefit. The younger the fracture is, the better your results are. So our best results are in the first 4 weeks, 4-6 weeks. But the oldest case that we treated was 1 year old. The patient could not undergo surgery when she had a fracture, and she came 1 year afterwards to the hospital, and she was still in pain, and we treated her, and we still were able to correct the kyphosis. Not as much as we would like, but we can do it after 1 year.
Thank you.
Thank you. Sorry. Thank you for your attendance. Because time for the next sessions. We turn this meeting place to the next session. Thank you very much for your attention.
Thank you very much for your